I'm a specialist, and today we will be reviewing how to scan a fetal head. The first part will be theoretical, and during the second part, Dr. Suresh will perform a live demonstration. The objective of this lecture is to describe how to examine the head. I will describe how to obtain the 3 planes required to assess the head and the 3 planes required to assess the face. The 20+2 plane is a methodology of the ISUOG to standardize the measurement and the way of obtaining the image to examine the fetus, the amniotic fluid, and the placenta. Today, I will only focus on plane 4, 5, 6 to evaluate the fetal head and planes 18, 19, 20 to evaluate the face. To examine the head, the first plane is a transventricular plane, which is the most cephalic plane. This plane is very important because it gives you important information about the skulls, the falx, the cavum of the septum pellucidum, and the lateral ventricles. From this plane, you can detect anomalies such as anencephaly, encephalocele, holoprosencephaly, and ventriculomegaly. Some millimeter down, parallel to the transventricular plane, you find the transthalamic plane, which is the plane that we use to measure the head. Also, some millimeters down, and after rotating the probe towards the posterior fossa, we find the transcerebellar plane, where you can see the anatomy of the posterior fossa, the cerebellum, and the vermis. In this plane, you can detect posterior fossa cyst, megacystana magna, hygroma, and scalp edema. Let me now explain you how to obtain these planes. The technique is the same if the fetus is in cephalic or podalic position. First, we need to obtain a longitudinal view of the spine. And then we move the probe towards the neck and the cranium, and we rotate the probe 90 degrees to obtain the transventricular plane. Once we obtain the transventricular plane, we can slide down to the transthalamic plane and rotate again through the posterior fossa to obtain the transcerebellar plane. In this video, you can see the things in real time. You start from the sagittal section of the baby, where you see the cervical spine. You move through the occiput, and you rotate the probe 90 degrees and move a little forward to find the head. You will obtain the transventricular plane and the transthalamic plane. Then you rotate the probe towards the occiput for the transcerebellar plane. It takes about 3 to 4 seconds to get all this. I will now describe what we can see in each of these 3 planes. First, in the transventricular plane, we can evaluate the integrity of the skulls. One quick look going around the skulls confirms that it appears intact. We can evaluate the bone density. The skull bone is usually expected to be quite bright, but more importantly, if you look at the near field, you will find it's quite easy, whereas the far field is very clear. If you don't see the near field, it's a good thing because it tells you the bone is well mineralized. You can see the midline falx, which should be interrupted by the cavum septum pellucidum and seen as an equal sign in the lateral portion. You can see the occipital horn of the lower lateral ventricle. The near lateral ventricle is almost always impossible to see because it's behind the skulls. And finally, you can see the frontal horn of both lateral ventricles seen as the 2 black spots in front. Using this plane, you can measure the lateral ventricle, and it's very important to do this measurement in the correct plane to avoid potential error in the measurement. If it looks abnormal or your measurement is abnormal, you should refer the patient because that means there is something wrong happening in the brain. You need a symmetrical axial view with an optimal zoom. The 2 hemispheres must be exactly equal with the midline in the middle. You should measure the atrium at the level of the glomus of the choroid plexus in front of the parieto-occipital sulcus. The caliper are placed touching the inner edge of the ventricular walls, and if the measurement is more than 10 millimeters, you should refer the patient. Now comes the transthalamic plane. In this plane, you can evaluate the midline falx, a little bit of the cavum of the septum pellucidum, the 2 thalami separated by the falx, the hypocampal gyri on both sides, and the lateral sulcus. In this plane, you can also measure the head biometry. The important thing is to identify the midline falx and place your calipers in a way that your parietal diameter and the occipital frontal diameters are perpendicular to the falx. The cerebellum should not be visualized in this plane, and it's very important because if you see the cerebellum, that means that you have angled your probe too far downwards and you won't get correct measurement. Finally, the transcerebellar plane, a few millimeters down the transthalamic plane, and after a little rotation through the posterior fossa, you can see the cerebellum completely. There is some fluid around. This is the cisterna magna. It is also important that you see the midline falx, the frontal horn of both lateral ventricle, and the cavum of the septum pellucidum. You have to visualize the cavum of the septum pellucidum and the cerebellum together to ensure that you are taking the cerebellum in the correct plane. The thalami are also seen, and the cisterna magna is seen behind the cerebellum. In this plane, you can also measure the transcerebellar diameters and the cisterna magna. Measure from the vermis to the inner edge of the occipital bones. Now to examine the face. ISUOG recommends that the examination includes the visualization of orbits, upper lip, and if technically feasible, the sagittal profile. To obtain the coronal section of the face, you start from the transventricular plane and you slide down. When you see their orbits and the cerebellum, you rotate the probe between 45 and 70 degrees, and you will obtain the coronal section of the face. Here you can see an example. First, the transventricular plane, then you slide down toward orbit and cerebellum, then you rotate to obtain the coronal plane with a visualization of nasal tips, and lips. To obtain the orbit plan, you also have to start from the transventricular plane, then you slide onto the orbit and cerebellum, then you need to slide laterally to place the transducer in front of the orbit on the same plane. Here is another example. First, the transventricular plane, then you slide down in parallel until you find the orbit, and you slice laterally in the same plane to face the orbits and the face. The presence of both orbits and normal position and separation of the eyes should be checked. Finally, to obtain the facial profile, from the transventricular plane, we slide down to the cerebellum and orbital plane as we did to look at the lip. Then we angle through 90 degrees to produce the mid-sagittal section. And we need to ensure that there is an imaginary line between the forehead, the chin, and the lips. And all of these elements are all in line. So from the transventricular plane, we slice down to the cerebellum and orbital plane, and we angle through 90 degrees to produce the mid-sagittal section. Thank you very much for your attention, and let's see now how we can obtain this plane in real condition. Thank you.
Thank you, Romain, for this presentation. This was the theoretical part, and now we will pass to the practical part with Professor Suresh Seshadri. I don't need to do the presentation of Professor Suresh. He's a friend. He's a trustee for ISUOG. He has been one of the founders and most active member of ISUOG basic training. The basic training courses he has done were the most impressive ones, and I think he has in his CV like educating more than, I don't know, like half the planet in ultrasound. He has a mission, and I always thank him for all the energy he's putting into all that. He has done a lot also in practical ultrasound education, be it on real patients and on simulators. So he will try now to show us how to do the part of the face and the brain in basic training. The floor is yours, Suresh.
And then now we've got a longitudinal view, getting a full sagittal view of the spine. Plane 4, 5, 6 is actually go to the head and go up to the head. And plane 4, 5, 6 is nothing but the transthalamic plane. You go a little up, you get the transventricular plane. That's your transventricular plane. And then slightly rotate your probe towards the occiput to get the transcerebellar plane. That's your transcerebellar plane. So when you want to do biometric measurements, we are going to do biparietal diameter, head circumference, abdominal circumference, and femur length. That is the routine biometry. So for getting the head circumference, I want to trace the spine of the baby, and once I get to the spine of the baby, spine means I'm getting the cervical spine close to the occiput. I can either get a longitudinal section or I can get a coronal section like this. Now I just rotate my probe 90 degrees and keep going upwards till I reach the head, and there I am looking at the transthalamic plane. You can see the two thalami, which is brought out very well. Can you freeze the image? Now I can measure the biparietal diameter and set circumference at this level. So for this, I need to zoom the image. I'm going to do the outer to inner measurement, making sure that I am exactly perpendicular to the fox. I got the measurement there. Then I will go and measure the head circumference or the occipitofrontal diameter. So that's my occipitofrontal diameter. In this, I measure outer to outer along the fox cerebri. Okay, measure the occipitofrontal diameter and the head circumference is automatically calculated. I can also use the ellipse to get the head circumference. Okay, when I do the head circumference, I start off from the occipitofrontal, and once I get here, so I'll go that, and then I'll adjust it such that it is fitting the head. So I measure the head circumference. So two methods of measuring head circumference, either the BPD OFD method or the ellipse method. I think this is important. So here, just for you to understand where we have placed the probe on the fetus. So that's your biparietal diameter, and we have moved the probe so that we get the transthalamic plane. One additional biometry, one is the transcerebellar diameter. The beam is angulated slightly towards the occiput. As she is angulating slightly towards the occiput, you can see the cerebellum coming up. The zooming is extremely important for all biometric measurements. I'm going to get the outermost to the outermost bicerebellar diameter. The last thing now we'd like to show you is the lateral ventricle measurement. Let's go to the transventricular plane. This is the transventricular plane. So now I can see the lateral ventricle. So I'm going to take a measurement. I'm going to use the inner to inner measurement of the lateral ventricle at the level of the glomus of the choroid plexus. And at this point, you will also see the pareto-occipital fissure there. The biometric measurements. So we have completed. So this is how the transcerebellar plane is rotating, and you go upwards with the beam to show you the transventricular plane, and now you are in the transthalamic plane. Next is we need to go to the last three planes, 18, 19, 20. For this, what we will do, we will go straight to the head, plane number 4. So once you have plane number 4, we go to plane 18, rotate the probe, okay, and slide it down the other way, slide it to the opposite way. There, you are now getting the, go little bit more, slide it to get the, need to get the orbits first. Okay, slide it, there, you can see the orbit, then further, slide further to get the nose and mouth. You have to dip the probe a little bit to get that, yeah. So that is the mouth, upper lip, lower lip, and the nostrils. Okay, so that is plane 18. This is plane 18, upper lip, lower lip, and nose. Then you go to move up to get the orbits. So we are in this plane now. So you can move little backwards so that I can see the orbits. So as you're going to orbit, there you can see the orbits now. So as the beam is hitting the orbits, you can dip it a little bit. Both orbits are seen beautifully now, right? Then what we do is go to the mid-sagittal view by rotating your probe 90 degrees from here and bringing it to the front of the baby and coming in front, and then angulate it so that you get a mid-sagittal view of the face. So what you did, you went from the coronal view, you took a 90-degree turn, and you got a beautiful mid-sagittal view of the face, showing the nose, that's the maxilla, and the mandible, and so maxilla and mandible, which is there.
Thank you, Professor Suresh, for this demonstration. As I already told you in basic training, we're working on practical training also. We have done a lot of work on real patients, but a lot on simulators, as you saw in this video. This is a demo of the examination of the face and the head on a simulator where you can see the probe and the plane and the orientation of the beam, the ultrasound beam. So this is quite very rich in educational material, and I always thank Professor Suresh for doing these videos that I would like to integrate in the educational material that you get when you do the basic training online program. We will pass now to the next presentation with Dr. Divya Singh, who is also one of the most active members of the basic training committee. She has never been a part officially of the basic training committee, but has done more work than all of us. She is an active member of ISUOG. She's the chair of the CME subcommittee and is also very active in the outreach committee. Divya, we thank you for everything you're doing for ISUOG and ultrasound education and in the basic training also subcommittee. You will present for us now the examination of the heart on a real patient and on simulator to illustrate how we can train you. The floor is yours.
Greetings of the day, everyone. Let's get started with examining the fetal heart. Now, when we have to move from one place to another, we first need to know where we are based and also where we plan to go so that we can decide the shortest possible route using our navigation system. Similarly, when we are to assess the fetal heart, we need to first understand the fetal presentation, that is the part of the fetus overlying the maternal pelvic inlet, and the fetal lie, which is the relationship of the long axis of the fetus with the long axis of the uterus, so that we can scan the heart in order to determine the situs and assess the 4 cardiac planes of the 20+2 plane approach. Common fetal presentations are the vertex or cephalic and breech presentation, whereas fetal lie can be longitudinal, transverse, or oblique. In order to assess the fetal presentation, the probe is placed in the transverse manner in the suprapubic region, as you see here. And in this fetus, what you appreciate in the ultrasound image is the fetal bladder, which indicates that this fetus is in a breech presentation with the sacrum overlying the maternal pelvic inlet. In order to orient yourself with the rest of the fetus, what I will do is then move my probe cranially, again in this transverse plane. As you see in this video, I'm moving my probe cranially towards the maternal head, just sliding it so that now I see that the spine is situated posteriorly at 6 o'clock position. And when I rotate my probe anti-clockwise, I get this longitudinal section of the fetus with the spine directed posteriorly, the head up, and the sacrum overlying the pelvic inlet. So now I understand that this baby is in a breech presentation and in a longitudinal lie. Now, in order to determine the laterality of fetal situs, what I need to know is the position of fetal head and spine. And I already know from the previous clip that this baby is in a breech presentation with its spine at 6 o'clock position, that is directed posteriorly towards the maternal spine. Now, with these 2 pieces of information, one can either imagine oneself to be lying like how the fetus is lying and then determine the fetal left or right, or it's more easy to use a doll. And you can see in this illustration that the baby has been positioned in the breech presentation with the head up and the spine posteriorly towards the maternal spine. So in this case, this is the fetal left, this is the fetal right, and you can see that the fetal left is seen on the right side of the screen, whereas fetal right is seen on the left side of the screen. So correspondingly in this image, fetal left is on the right side here, and we can see the cardiac apex directed towards the fetal left, as well as the stomach on the fetal left, indicating that the baby has situs solitus. Now, where do the rest of the planes of the heart lie? Well, heart is assessed by using 3 axial, namely planes 7, 9, and 10, and 1 oblique plane, that is plane 8, which is the plane of the left ventricular outflow tract. Now, since the left ventricular outflow tract is directed towards the fetal right shoulder, we have an oblique plane for assessing it. Now, how do we go about assessing the 4-chamber view? To assess the 4-chamber, which is the axial view of the heart, first we need to have an anchor or base plane, which would be the longitudinal section of the spine, as you see here. In order to obtain the longitudinal section of the spine, you can see that in this fetus, I have directed the probe such that the orientation dot is towards the maternal head, because we know that this baby is in a longitudinal lie. Now, in order to obtain the 4-chamber view, first we take the probe in a longitudinal plane towards the level of the heart, and then we rotate the probe 90-degree anti-clockwise, as you see here. I'll rotate the probe 90-degree anti-clockwise in order to obtain an axial section of the chest at the level of the 4-chamber. And this is how the 4-chamber view looks like real time. It's an axial view of the heart. The cardiac apex is directed towards the left. We see the 4 cardiac chambers, and we see the homogeneously echogenic lungs on either side. Now, what are the relevant anatomy or landmarks that we need to assess in order to say that a 4-chamber view is normal? First, as I pointed out earlier, this plane 7 or 4-chamber view is used to assess or look for fetal laterality and determine fetal situs along with the plane of the upper abdomen, which is plane 11. Normally, the cardiac apex and the stomach should be towards fetal left if the baby has situs solitus. As you can see in this image, heart normally occupies 1/3 of the chest. Majority of the heart lies in the left chest, which can be determined by drawing this simple line, which is antero-posterior from the sternum to the spine, bisecting the chest into 2 equal halves. And you can see that the bulk of the heart lies to the left of this line. The cardiac apex, as I pointed out earlier, points towards the left normally. Another measurement that we can take here is the measurement of the cardiac axis, which is determined by first having this antero-posterior line from the sternum to the spine, and then drawing a second line intersecting it. And this second line, as you see here, goes through the cardiac apex, the interventricular septum, and the septum primum. And the angle that we see in between these 2 lines is the cardiac axis, which is normally 45 degrees plus minus 20 degrees. Cardiac axis can be altered in case of outflow tract anomalies of the heart, and that is why an abnormal cardiac axis is a red flag. Also, cardiac axis can be affected if there is some abnormality in the adjacent lungs. When we look at the heart in the 4-chamber view, we not only see the still image, but we also look at the heart real time, and so it's important to ensure that it is beating regularly. The 4 chambers that we assess in this view include the left atrium, which is the most posterior chamber of the heart. As you can see, it is closest to the spine, and it is the chamber in which the pulmonary veins drain. In the 4-chamber view, you can see twigs of at least 2 pulmonary veins draining into the left atrium. The left atrium is connected adjacent to the right atrium by the foramen ovale. This thin linear strand or septum that you see separating the right atrium from the left atrium is the septum primum. So through the foramen ovale, the right and the left atrium communicate, and the blood is directed from the ductus venosus to the right atrium into the left atrium through this foramen. Now, right atrium communicates with the right ventricle across the tricuspid valve, whereas the left atrium communicates with the left ventricle across the mitral valve. What we appreciate here is this normal offset between the tricuspid and the mitral valves, and what this implies is that the tricuspid valve is normally slightly more apically situated as compared to the mitral valve. Also, the right ventricle, which is the most anterior chamber of the heart and is situated beneath the sternum, has this band of muscular tissue at its apex, which is known as the moderator band and is the signature for identifying the right ventricle. On the other hand, the left atrium has relatively smooth inner walls and is devoid of this moderator band. It is the left ventricle which forms the cardiac apex. The two ventricles, as you see here, are separated by this interventricular septum, and the interventricular septum, the tricuspid valve, the mitral valve, and the septum primum join in the center of the heart to form what is known as the crux of the heart. The normalcy of the crux of the heart is very reassuring, as it helps us in excluding several abnormalities. Now, behind the heart, you see this round anechoic structure slightly to the left of the spine, which is the descending aorta. Also, do not forget to look at these homogeneously echogenic lungs, the right and the left lung on either side of the heart every time, because sometimes the heart may be absolutely normal, but there may be a lung abnormality. There is said to be significant pericardial fluid if the thickness of fluid around the heart comes out to be more than 4 millimeters. Normally, there should not be any significant pericardial effusion. Now, moving on, let's come to the oblique plane for assessing the left ventricular outflow tract. Now, to obtain the LVOT, or to assess the left ventricular outflow tract, first we will have our base or foundation plane, that is plane 7, or the 4-chamber view of the heart. And from here, we will rotate our probe towards the fetal right shoulder, as you will see in this clip. As I play this clip, initially I've placed my probe in a transverse fashion to obtain the transverse 4-chamber view, and now I'm going to rotate it towards the fetal right shoulder in order to obtain the oblique plane of the LVOT. This corresponds to the same in the graphic, and you can see how we rotate the probe from the axial 4-chamber view in order to obtain the left ventricular outflow tract view. So initially, we have an axial position or transverse position to obtain the 4-chamber view, and then we rotate the probe towards the fetal right shoulder here so that we can get the LVOT view, because the left ventricular outflow tract and the aorta go towards the fetal right shoulder. Correspondingly, on the ultrasound screen, initially you will see an image of plane 7, as you see here, and then you will see the left ventricular outflow tract once you rotate the probe. What is the anatomy of the left ventricular outflow tract view? Well, in the center of the view would be the left ventricle, as you see here. And what we look for here is the continuity between the interventricular septum and the anterior wall of the ascending aorta, which is known as the septo-aortic continuity. Posteriorly, the mitral valve leaflet is continuous with the posterior wall of the ascending aorta. The interventricular septum separates the left ventricle from the right ventricle, and the posterior mitral aortic continuity separates the left ventricle from the left atrium. Any discontinuity in this septo-aortic line would be suggestive of a subaortic ventricular septal defect. Coming to the other two axial views of the heart, the RVOT, or the right ventricular outflow tract, and the 3-vessel trachea view. Again, the base or the foundation planes to obtain these two anchor planes is first the 4-chamber view of the heart, from where we will simply slide our probe towards the baby's head to get plane 9, or the RVOT view, and then slide it more cranially to get plane 10, which is the 3-vessel trachea view. Now, this is the probe movement that you do from the 4-chamber view. You simply slide your probe up, as I'm sliding it now, to first get the RVOT view, and then slide it further up towards the fetal head, as you see me doing, again in the transverse plane, to get the 3-vessel trachea view. And this is how it looks in the animation, where first you get the 4-chamber, then the RVOT, and then the 3-vessel trachea view by simple sliding movements of the probe towards the fetal head. On the screen, what you see when you look, first you see the 4-chamber view, or the plane 7, and as you start moving cranially, you see the aorta emerging from the left ventricle. So you appreciate the crossover of the aorta. You see this aorta emerging from the left ventricle here, and once it goes towards the right shoulder, you can see the right ventricular outflow tract emerging anteriorly from the right ventricle and crossing over to give you the right ventricular outflow tract view. So this would be the pulmonary artery, which is the vessel to the most left and is the largest in size, followed by the aorta and then the superior vena cava, which are remembered by the mnemonic PAS, P-A-S. One can identify the pulmonary artery by the fact that it bifurcates into the right and left branches, as you see here. The relevant anatomy of the right ventricular outflow tract shows you the outflow tract emerging from the right ventricle, and this thin leaflet is that of the pulmonary valve. The vessel that emerges beyond the pulmonary valve would be the main pulmonary artery, and you can see the right pulmonary artery branching out from the main artery and coursing behind the aorta and the superior vena cava as it goes towards the right lung hilum. The main pulmonary artery in this view continues as the ductal arch and joins into the descending thoracic aorta. Coming to the most cranial view of the heart, which is particularly important to assess the outflow and the arches, and that is plane 10 or the 3-vessel trachea view. Again, a simple sliding movement from plane 9 would give us plane 10. As you can see in this clip, we get plane 10 by a simple sliding movement, and plane 10 shows you both the arches, namely the ductal arch, which is on the extreme left, the aortic arch in the middle, and then the superior vena cava on the right. Both the arches are situated to the left of the trachea, and this black dot that we see here is the trachea. 3-vessel trachea view is a very good view and obtained quite easily to assess the outflows and the 2 arches. Seeing the relevant anatomy of this plane, one can appreciate the pulmonary artery continuing as the ductal arch, the ascending aorta continuing as the aortic arch, and both of them join the descending aorta. This round structure in the center is the trachea, and we can appreciate both the arches joining to form a V to the left of the trachea normally. The 3rd vessel to the extreme right, and usually of the smallest caliber, is the superior vena cava. Also, one can appreciate the upper lobes of both the lungs as relatively homogeneous echogenic structures on either side. Another important structure which can be seen in this plane is this relatively hypoechoic structure anterior to the great vessels and behind the sternum, that is the thymus. So this is a good plane to assess the thymus when we are suspecting thymic hyperplasia or aplasia, as in 22q11 microdeletion. This is another image showing you this 3-vessel trachea view, illustrating the relevant anatomy.
Thank you, Divya, for this presentation and for concentrating this all this educational material in 15 minutes. We really appreciate how we can manage to demonstrate this technique for heart examination on simulators and also train you on real patients. So we've done like a small overview of obstetrical ultrasound and how we can examine and teach this this part of the basic training. The second part of the basic training concerns the gynae exam, and I'm honored to welcome Dr. Shabnam Bobdivana, who was with us from the start in the ISUOG basic training subcommittee and has designed or supervised the conception of the gynae part of the basic training and the gynae lectures, and she's still a basic training subcommittee member and very active. She's working in the Imperial College in London, and the next presentation will be about gynae and early pregnancy in basic training. Thank you, Shabs, for being with us and for the presentation.
Hi, everyone, and thank you so much to the committee for the invitation to speak to you today at this basic training webinar on specifically the gynecology and early pregnancy component of basic ultrasound training, which I've been quite heavily involved in, and it's been a real passion of mine over the last few years. So the gynecology component of the basic training lectures are essentially 7 main lectures, and we walk through starting off with really the fundamental basics of gynecological ultrasound, and then we break up the gynecological tract into separate entities and look at them individually, so such as the cervix, endometrium, myometrium, and then finally the ovaries and adnexae. We also look at typical ultrasound appearances of the most common pathologies in the adnexae, but it was very intentional that when we were assessing pathology, we didn't make anything too advanced or complicated, because this is meant to be a basic training ultrasound program after all, and we didn't want to move beyond that. We do hope that there'll be intermediate and advanced ultrasound training programs with ISUOG in the future, but this is very much focusing on the basics. Because of that, we also have a very specific lecture looking at writing the gynecological ultrasound report, because we argue that being able to write an accurate report that isn't misinterpreted by the reader is as important, if not more so, than performing a competent ultrasound examination. So there's a specific lecture on that. And then early pregnancy is very much within the domain of gynecology, but I put the lecture of assessing normal pregnancy between 4 and 10 weeks in brackets, just because if you look at our lecture schedule, it goes slightly higher, so it fits in nicely the obstetric lectures, which then also after that look at the pregnancy from 10-week onwards. I thought one of the most interesting ways to maybe summarize some of the key messages within those 7 lectures was to do question stops that you can get involved in. So we'll start off with our first one. What do you think are the benefits of a transabdominal versus a transvaginal approach to the gynecology ultrasound scan? And we're looking at 4 main domains of resolution, frequency, overview, and views of the abdomen. And I hope you felt that performing a transvaginal ultrasound scan certainly gives you much better resolution and better frequency, but a transabdominal ultrasound scan has the benefits of giving you a broader overview, particularly with views of the abdomen, which you lack when performing a transvaginal scan. Also important to state that image quality is very important here, and in terms of optimizing your image, ideally your bladder should be full for a TA scan and empty for a TV scan. We also specifically look at key points within the lectures. So one of them is orientation. And if you're looking at your transvaginal probe, so most people will have a dot which they place their thumb on, and then that thumb aspect denotes the anterior portion of the scan that you're looking at, and then below it the posterior. And when we're in the sagittal plane, we tend to move our hand from side to side, up and down in the transverse plane, and then we often do slight rotational movements, which are often very small in both planes to try and optimize our image. But orientation is key in understanding where your thumb is, so at that 12 o'clock position in relation to your ultrasound scan. And just to say, people scan in different ways. Everything I'll be talking about is the way that I scan, which is with my probe view at the top of the screen rather than at the bottom. So one of the ways to demonstrate this, so where my thumb is, where that dot is, that denotes the anterior portion. So if we're looking at this, the uterus, so coming down from the cervix, the endometrial lining here, and we've got the fundus up here. If this is anterior, then our bladder will be here and our bowel will be here. So this is demonstrating an anteverted uterus because our uterus is tilting towards the anterior portion of the abdomen, i.e. the bladder. In contrast to this, a retroverted uterus will flex away from the bladder, and actually the fundus will be pointing towards the posterior component of the abdomen, i.e. the bowel or the colon. And so what you'll see is a uterus that looks something like this when it's retroverted. So moving on to our next question stop, which is the correct way to measure the uterus, A or B? And I hope you all felt that it was A, and this is demonstrated really clearly and described so eloquently in a paper by Thierry van den Bosch and his colleagues, which I've referenced here, which states the importance of a standardized way of measuring the uterus. We know it's a 3D structure, so you look at the length, the anterior-posterior measurement, and the transverse measurement, and it tells you how to do that when looking at the uterus. The other key point here is optimizing your image and making sure you're getting the correct sagittal and transverse views before you go on to start your measuring. So you can look here that the image is blurry, it's certainly nowhere near the correct sagittal view that we should be obtaining compared to this as we move along, where we have a lovely view of the uterus and we can see the fundus, a nice endometrial midline demonstrated all the way through. So that's the correct sagittal view, and that's what you should be measuring. If you don't get the view accurate, your measurements will be inaccurate. irrespective of whether you use the standardized methods described in that paper by Thierry's team. And same thing for the transverse measurement. So next question, stop. Normal fallopian tubes, i.e. those that don't have any pathology, are usually visible on a transvaginal ultrasound scan. Is that true or false? It is indeed false. The more scans you perform, the more you will note that actually very rarely can you see a normal fallopian tube. You either see it because it's got some form of pathology within it, or very rarely we might be able to see it if there's fluid around the fallopian tubes or demarcating, particularly the fimbrial end, but that tends to be not particularly common. Next question, stop. What is the correct definition of an intrauterine pregnancy of uncertain viability, so an IPUV? Is it A, where you can't locate the pregnancy either inside or outside the endometrial cavity on transvaginal ultrasound scan? Is it B, when the mean sac diameter measures less than 25 millimeters and the fetal pole measures more than 6 millimeters? C, where neither a diagnosis of a viable intrauterine pregnancy or a non-viable intrauterine pregnancy can be confirmed? Or finally, D, where you can visualize a fetal heart rate, but it's slow. And I hope you all felt the answer was C. So A is describing a PUL, a pregnancy of unknown location. B is not really describing anything, but certainly if an MSD is more than 25 or a fetal pole is more than 7 millimeters, we know that can be diagnostic of a miscarriage. C is the correct answer, and D is not really describing anything either. Visualizing a slow heartbeat in a fetal pole is indicative, but certainly not diagnostic of anything. And final question, stop. We've got time for one more. This image was taken from a transvaginal scan of a 28-year-old female. She'd been classified as having a pregnancy of unknown location 3 days ago and re-presents with severe pelvic pain. So what does this image demonstrate, indicated by the yellow arrows? It's not the best quality image, but I'll just orientate you slightly. So this is an empty bladder. Okay. This is the uterus